So feel free to start whenever you're ready.
Okay. So hopefully if you guys, today we're going to talk about hemodynamics. Specifically, we're going to use pressure volume loops and kind of dissect them a bit. This curriculum is based off of the TEACH curriculum, which was developed by Dan Burkhoff over at the Cardiac Research Foundation, CRF, Cardiovascular Research Foundation. Some of this, I think that it really helps as far as getting the basic concepts down. And then as you continue to go through your training, a lot of this stuff will slide into place and kind of make more sense as you go. Some of these concepts are probably concepts that you've heard about in med school. Some of the concepts are probably just concepts that we throw around, but I think it helps to kind of formalize a little bit. And then from this is kind of where we build, and when we, as a cardiologist and as a heart failure cardiologist, we use a lot of these concepts when we think about patients and how we treat them. So feel free to stop me at any time. I'll try to make it a bit interactive. If you have questions, I want this to be as casual as possible. So please jump in at any point. So we're going to basically review some basic principles. We're going to discuss the definitions and indexes of preload, afterload, contractility, lusitropy. Try to understand how these changes in parameters manifest in a pressure volume diagram. And hopefully we'll have time. We'll talk a little bit about myocardial oxygen consumption and talk a little bit about how things become altered in heart failure, because I think that is helpful from a hemodynamic perspective. So the pressure volume loop goes back to the 1920s or 1930s, which was initially developed by Carl Wiggles and has essentially been used since then really to try to talk about and learn about cardiovascular hemodynamics. And essentially, when we look at the pressure volume loop, we're essentially looking at a left ventricular pressure volume loop, although we use the concepts and we kind of extrapolate them to other aspects of the heart, including the right ventricle and the right and the atrium as well. Although it's important to note that the properties tend to be somewhat different. So if we just start looking at a basic pressure volume loop, as we look here, you have your X and Y axis, which is LV pressure and LV volume. And then going through the cycle, you can see that on the corner of each part of the cycle, you have valves opening and closing, which you guys are probably familiar from med school. And so basically starting at this bottom right corner, you have the mitral valve closes, you have isovolumic contraction, which is the ventricle contracts, but at the same volume. When it reaches a certain pressure, the aortic valve opens. The ventricle ejects, which you can see here. Then the aortic valve closes. You have isovolumetric relaxation. The mitral valve opens again, and then it fills. So what would you think about the area in the inside of this pressure volume loop? What would you think that area represents? Free anyone to jump in. It's the difference between, so no takers for the first one. Well, so basically that's your stroke volume, right? So if you're looking at, if we know what the end systolic pressure volume is and the end diastolic volume is, then you know what your stroke volume is. So on a pressure volume loop, when we talk about this, the width of the pressure volume loop, we're talking about stroke volume, which is the amount of blood that the heart ejects with each beat. And when we think about, you guys have probably remember learning this, cardiac output is stroke volume times heart rate, right? So if you take theoretically the stroke volume of the pressure volume loop multiplied by your heart rate, you would have your cardiac output. And in looking at it, if you take your stroke volume, which is the amount that the heart ejects with each beat, and you divide it by the total amount of volume, end diastolic volume that's in the heart, then you have your ejection fraction, which is what we loosely throw around all the time, right? We say, oh, the patient's ejection fraction is 30 or 50 or 40. So in truth, that's really, we all know that, but that's really what it means is how much your stroke volume is relative to your end diastolic volume. And in thinking about the curve when we go around, so I talked about that the corners usually represent valves opening and closing, but they also represent specific pressures, which are quite important. So we talked about here where you have the mitral valve close. So you basically, this is the left atrium fill. This is the end diastolic pressure. right? What we say is LVEDP, which is the same thing as saying that if you hear a patient who has had a right heart catheterization or has a swan in place, and someone says, oh, what's the wedge pressure? Well, that's the same as your left ventricular end diastolic pressure. It's a surrogate, right? And then if we think about the isovolumetric contraction, well, when the aortic valve first opens, the pressure that it opens at, that's your diastolic blood pressure. And if you think about as the ventricle is ejecting, well, the top pressure that it reaches, that's your systolic blood pressure. And as before the aortic valve closes, that's your end systolic pressure. And then you have isovolumetric relaxation until you again have your mitral valve opening, and that first pressure is going to be equal to your left atrial pressure. And I think some of these, when you think about it, sometimes it's a little bit confusing, but over time, these things become, as you hear it more and more, they start to make sense. But in cardiology, they're quite important concepts, especially when thinking about hemodynamics. And when we look at a pressure volume loop, so basically every ventricle has its unique properties that are based on the myocardium. And every ventricle has what we call, every pressure volume loop, which represents each individual ventricle, is usually bordered between two boundaries. One is what we call the ESPVR, end systolic pressure volume relationship. And the slope of this line represents contractility. And the other is the EDPVR, the end diastolic pressure volume relationship, which relates to your diastolic pressures or your compliance and stiffness. And I'll talk about that a little bit more. And these boundaries are kind of where, within these boundaries is where any given ventricle operates. So based on your set contractility, and there are things that can change that, which we'll talk about, but usually based on this, so based on your afterload and your preload, based on your afterload and preload, your pressure volume will fall within certain parameters within these boundaries. And I put this here just to remind you that I said that we use a pressure volume move of the left ventricle to extrapolate principles to the right ventricle and to the atrium as well. But you can see here, if you look on the left, this is a right ventricular pressure volume loop. It's quite different than a left ventricular pressure volume loop. And there, some of the main things that are different about the right ventricle, just to keep in mind, and I'm not going to go into it further than that because it's beyond the scope of this talk, is that one is that the right ventricle is a low compliance system, right? Right-sided pressures are much lower than left-sided pressures, and pulmonary pressures are much lower than left-sided pressures. So you don't really have a isovolumetric contraction or relaxation. The other thing to remember is that the right ventricle is going to be much more afterload sensitive than the left ventricle. And that predominantly relates to the fact that the right ventricle is a very thin-walled ventricle when compared to the left. So it's much more afterload sensitive. So let's talk about preload first. So preload is your hemodynamic load or your stretch on the myocardium. And the two markers the two measurements that we use of preload is, one is the end diastolic pressure and the other is the end diastolic volume. Both of those can be quite different because for a given ventricle, a certain end diastolic pressure may be a different volume than another ventricle, and vice versa with volume, right? A certain end diastolic volume, volumes may represent a different pressure depending on the ventricle you're looking at. So we use both of those sometimes as measures of preload. So saying what's the end diastolic pressure or what's the end diastolic volume to say how much preload there is. And the peak, a key concept in preload is the peak isometric force increases basically as the sarcomere length is increased. So as you increase your preload, you theoretically stretch your myocytes, and as you stretch your myocytes, the amount of force that the myocytes can generate increase, which we call the Starling curve, which we call the Starling effect. And I'm sure everyone is familiar with the quote unquote Starling curve, which we talk about all the time. And basically what you're seeing here is the sarcomere length force relationship. And you can see that as your length increases, your total amount of force that you can generate increases as well. Now, this is just showing you, so here on the right, you can see here's end diastolic pressure. So as I increase my end diastolic pressure, you can see that the amount of my pressure volume, the stroke volume that I generate increases. So my cardiac output increases. And you can see that here, as I increase my end diastolic pressure, my cardiac output is going up. Now, what does anyone notice about specifically this curve on the right? Feel free to jump in. What do you notice about the curve?
Kind of like diminishing margins of return. Once you keep increasing end diastolic pressure, it's not like you're going to get more cardiac output. It plateaus essentially.
That's great. Yeah. Really key point, which is exactly right. Like at a certain point. So what would be the clinical scenario that we're talking about? I mean, forget about the diminishing, but I'm saying the clinical scenario, right? You have a patient, you're giving them volume, let's say, because you say, wow, they need preload, you want to increase their cardiac output. So you give them volume, and at a certain point, they're quote unquote volume responsive, right? And you see their cardiac output increasing. And then you hit another point where you give them more volume, but now you're not seeing much increase in cardiac output, right? So you're exactly right. You know, the relationship gets to a point where you're on the flatter part of the curve. And so for increases, as you can see that going from an end diastolic pressure here of 5 to 10 or 10 to 15, you're going to generate much more cardiac output than going from 15 to 20, if you think about pressures, right? And again, just to remind everyone again, end diastolic pressure is another LVEDP, which is something we can measure in the cath lab, is the same measurement we use when we put a swan in, or we say, what's the pulmonary capillary wedge pressure? And it's the same thing when we say, what's the left atrial pressure? So essentially saying is, what is your left atrial pressure? Now, what's another thing what else do you notice about the curve here? This is, you may not get this, but what is a term you always hear thrown around, or a statement people say, well, he fell off the Starling curve, right? So he's off the Starling curve, and if we just get them back on the Starling curve, then his heart will work better, his cardiac output will increase. That's a concept that I think you hear a lot. And so for a normal ventricle, which this is of a normal ventricle, for a normal ventricle, the reality is that there probably is no negative part of the Starling curve. In other words, there's probably no such thing as truly falling off the Starling curve for a normal ventricle. Now that changes in an abnormal ventricle, and we'll touch upon that. But I think it's also just an important point to think about. So when we think about preload, and you can see here looking at the pressure volume loop. So you can see here that starting from the blue pressure volume loop and increasing to the red and then increasing to the orange is showing basically increased preload. And you can see that by different points of LV volume or LV end diastolic pressure. And with that, you can see that you generate higher pressures overall, higher systolic pressures, more stroke volume. And so you can see that, that's the impact of increasing preload. And to keep in mind, when I show you these pressure volume loops, let's say we look at preload, well, this is theoretically holding afterload and contractility constant. So this is just looking at the effects of what happens with preload. So you give someone preload, their stroke volume goes up, their pressure that they generate goes up. Now, what about afterload? So afterload is essentially the force the muscle has to overcome to shorten. So we talked about a myocyte that you stretch, and the more you stretch it, the more force it can generate. But then imagine if you have that stretched myocyte, as you can see here, and then you attach essentially a weight to it at the end as it has to do its force. That's what afterload is. So afterload is the force that it has to overcome to shorten. And there are there's a lot of different types of afterload. We hear the concept of people saying, oh, his afterload is high, we need to reduce his afterload. Clinically, usually what we talk about, we're talking about afterload clinically, is we use total peripheral resistance or systemic vascular resistance. And when we talk about that, we're talking about kind of a very global sense of resistance throughout the vasculature. And the way we calculate that, which I'll talk about a little bit later, is we take the change in pressure, which is the mean arterial pressure, minus the right atrial pressure. So the total change in pressure through the system. So if you think about your highest mean pressure, be your mean arterial pressure, and you think about the end of your system as blood travels out of your heart and around and all the way back to your right atrium, the end pressure will be your right atrial pressure. So you take your mean arterial pressure and you subtract your right atrial pressure. So you take your total pressure change in the system, and then you divide it by your cardiac output. That gives you your total peripheral resistance. And that's a lot of times what we use in cardiology when we're talking about what is the afterload. But it's important to keep in mind there are other aspects of afterload. So there's something called arterial impedance, which is essentially resistance to pulsatile flow. So it's quite difficult to quantify clinically, but in theory, what it's saying is for each time the right or left ventricle ejects, whether it's into the pulmonary artery or to the aorta, it creates waves of volume as it moves forward. And those waves kind of reverberate back against the heart as it tries to eject further. So arterial impedance looks at the resistance to pulsatile flow, or how those waves interact. We don't use that normally because we don't have a good way to quantify it. The other thing to keep in mind is aortic pressure. So aortic pressure can be a type of afterload too. But the problem with aortic pressure, why we don't use it when we're talking about afterload, is aortic pressure is not independent of ventricular function. And what that means is I can take two patients or you can have two patients that you're treating as an inpatient, let's say. They can both have blood pressures of a mean arterial pressure, let's say, of 100 and blood pressures of 140 over whatever, 100, let's just say. But very different ventricular functions, very different cardiac output. And when you look at their total peripheral resistance, one can have a very high resistance and one can have a normal resistance, but just much better ventricular function. And when you look at their actual blood pressures, the blood pressure will be the same. And so blood pressure in and of itself, while there is a component of it that is afterload, it's not a good measure of afterload. When you're looking at patients, you want to say, oh, the afterload is high or the afterload is not high. And then another type of afterload, which I think is important to keep in mind, is called ventricular wall stress, which is actually the wall stress on the ventricle. And the basis of that is called Laplace's law. And that's something I'll dive into just a little bit. But basically, the reason why afterload is important is you can look at here is the force velocity relationship. And essentially, simply all this is showing you is that as your afterload increases, as you can see here, your velocity of shortening decreases. And so your ability to generate force decreases with increasing afterload. Now, before we jump into that, just to keep in mind, and we'll talk about this, I'll mention this a little bit later, but so if you think about someone with a normal ventricle and the way these interplay, preload and afterload, right? So if you have someone normal with a normal ventricle, I don't want to say someone normal, but someone with a anatomically normal ventricle, and they all of a sudden have an increase, let's say, in afterload. So their blood pressure is very high, they're clenched down, they got very excited, maybe they did some drugs, whatever it is. And so if the normal course of events would be that as you have an increase in afterload, you would have a decrease in your ability to generate force. Because you have a decrease in your ability to generate force, you would have more volume, your stroke volume would be less, and you'd have more volume left over at the end of the beat because you couldn't generate as much force. So now, because you have more volume left over at the beat, your preload has become higher. And your preload would become higher. And as your preload became higher, your force generated would become higher because you now have your stroke volume go up because now you have more preload, and you would essentially compensate. So the average person, what we see is the interplay between, if you imagine preload and afterload, we have that interplay all the time. It's just it balances out. So if your afterload goes up, your preload goes up to compensate it, and vice versa. We'll talk about what happens when you have ventricular dysfunction later, but just to keep that in mind, how these interplay. So total peripheral resistance I mentioned before, which is basically your mean arterial pressure minus your CVP or right atrial pressure divided by your cardiac output. And basically it's the ratio between your mean pressure drop and mean flow in the arterial system. So what you're saying is how much pressure is there across the system, and you divide it by cardiac output because you want to say relative to flow. You want to take flow out of the equation because you don't want it to be dependent on ventricular function. You just want to know about the arterial properties. And we use this all the time when we think about patients, when we're thinking about, and it may be that their blood pressure is normal, right? Someone's blood pressure, a patient with heart failure's blood pressure may be 120 over 90 or 110 over 70. But we may calculate their peripheral resistance, which is systemic vascular resistance, and say that it's quite high. And what it is, we'll say, okay, we want to vasodilate them because of these relationships, because we know that if we vasodilate them, we'll decrease afterload or systemic vascular resistance, which will allow it to generate more force, which will increase their cardiac output. So we use kind of this concept when we're looking at patients all the time, especially on the inpatient side, when you're thinking about patients who have decompensated heart failure, who are coming in because they're short of breath, or they are low output. We are constantly balancing the resistance, because if you think about how these come into play, so systemic vascular resistance, if you think about heart failure patients specifically, all of the systems that the body reflexively uses to combat heart failure or low output or low blood pressure increased systemic vascular resistance. So whether it's increased sympathetic tone because it senses low blood pressure and low cardiac output, or whether it's initiating the RAS system and driving up the RAS system, all of those will increase your total peripheral resistance, your systemic vascular resistance. So all of these patients usually, until they're in cardiogenic shock, which is beyond the scope of this lecture, will have high systemic vascular resistances unless you treat it. And we compensate, we treat it by driving down or vasodilating, driving down the peripheral vascular resistance. Now, Laplace's law I briefly mentioned before, wall stress, which is important. Basically, the wall stress of a ventricle is, what you see here is proportional to the pressure and to the radius, and inversely proportional to wall thickness. And so what that tells you is, if you think about a ventricle, so if you have a ventricle that is, if you have a patient who is decompensated heart failure and what we say, when we say overloaded or hypervolemic, so they're going to have high filling pressures because they're full of fluid. When they have high filling pressures, you're going to have high pressure in your ventricle. You're also going to have a stretched ventricle, whether it's the right ventricle or left ventricle. And because of that, and in general, you're going to have ventricles that are, if their ejection fraction is reduced over time, they've probably dilated out, so they're going to have thin walls. So all of that is going to lead to a situation where they have very high wall stress, which is going to affect their ability to contract. And, as you diurese them, or let's say vasodilate them or treat them and drive down their pressure, drive down their radius or the diameter, you're going to decrease their wall stress and improve their ability, their contractility, or their ability to generate force. And, I had mentioned earlier, the right ventricle, even more so than the left ventricle, being a very thin-walled structure, is very, very susceptible to wall stress, which is why a lot of times, the old teaching, for the most part, used to be if you have RV failure, you give volume. But in truth, in most clinical scenarios, the answer is if you have RV failure, you diurese. And the reason why you diurese is exactly for this reason, which is that if you have high filling pressures in the RV, you're going to have very high wall stress, especially in a thin structured a thin structured ventricle. And by driving down filling pressures and decreasing the pressure on the right, you're going to actually increase the RV's ability to generate force, or you're going to improve its hemodynamics. And so this is a concept we use all the time. Now, I don't want you to think that you diurese to a filling pressure of 0. If you have RV dysfunction, you will need higher filling pressures, but in general, most of the time when you have very high filling pressures, the answer is to take off volume and decrease pressures rather than to give fluid or give volume. So if you look here at ventricular afterload, so this is where we hold contractility, because you see the ESPVR is constant. You hold contractility constant. You hold we hold preload constant, because all of these pressure volume loops are initiating at the same place on the EDPVR and end-diastolic pressure volume relationship, or the same volume here, the same pressure. But you can see that as your afterload increases, your stroke volume decreases quite significantly, and your pressure increases. So basically, with increasing total peripheral resistance or systemic vascular resistance, you're going to see increasing pressure and decreasing stroke volume, which means decreasing cardiac output, and vice versa with decreasing peripheral vascular. But vice versa, if you decrease your systemic vascular resistance, you will increase your stroke volume and decrease your overall pressure. This is just to show you that, just to keep in mind what we said, that this is the reason why arterial pressure in and of itself, or just looking at someone's blood pressure, is not a good marker of afterload, because you can see that both in preload and afterload impact the blood pressure that you're dealing with. So here's a little exercise. Let's see if how you guys feel about it. These are pressure volume loops at the top, and feel free to jump in and kind of give it your best shot. So which panel here shows an increase in arterial resistance or afterload from the baseline, which is in blue? Takers?
A.
Which one?
Panel A.
Excellent. So A. So you can see here that basically both of these pressure volume loops are starting at the same end diastolic volume or pressure, but you can see there's a significant increase in afterload here, which leads to a significant increase in overall pressure and decrease in stroke volume. And so if you look at these parameters below, how would these parameters be affected by an increase in afterload? So your LV end diastolic volume, let's say, how does that change if you have an increase in afterload? If you have an increase in afterload, your stroke volume will go down, right? Because you'll generate less force. And if your stroke volume goes down, so less blood is ejected with each beat, then the amount of volume you have left over for the next beat will be
increased,
right? How about your LV end systolic pressure?
probably increased as well then.
Increase. And how about your LV end diastolic pressure? Increase, right? Because remember, pressure and volume, that's when we talk about hemodynamics, we always talk in volumes, but we use we always talk in pressures, and we use pressures to essentially describe volume to the best of our ability, because usually we can't actually measure. Here on a pressure volume, we can, but when you're dealing with patients for the most part, you're measuring pressures, not volumes, because we're rarely able to measure volume. But in truth, we know that if your end diastolic volume increases, your end diastolic pressure will increase too. How about your systolic pressure if you increase afterload? Increase, right? And your end systolic volume also will increase because you're not able to eject as much from each beat. And your stroke work, which we'll talk about, let's ignore that for now. Heart rate, ignore because we're holding a constant. Stroke volume with afterload, we talked about, will decrease. Contractility, let's ignore because it's independent. Resistance will go up because that's another way of describing afterload, and we'll leave out diastolic capacitance. So let's talk about contractility. So contractility basically is the ability to generate force independent of preload and afterload. And basically what changes contractility is when the amount of calcium released or the affinity for calcium changes. I mean, that's truly what drives the force of contraction with each beat. And that shifts that boundary that we talked about, the end systolic pressure volume relationship. And if you increase or decrease contractility, it obviously affects stroke volume, it affects your end systolic volume and pressure generation. And your ejection fraction can vary quite a bit with preload and afterload as well, independent of contractility. And so things that we think about to increase contractility, right? So sometimes you'll take care of patients and they'll be low output and you'll put them on an inotrope, milrinone or dobutamine, right? Which milrinone is a PD3 inhibitor, dobutamine is a beta agonist. All of them work through the cyclic AMP pathway, but all of them ultimately what they do is increase calcium release and increase the ability, increase contractility via increased calcium cycling, which is the same reasons why we think of them as being pro-arrhythmogenic, which is also some of the reasons which I'll to mention a little later why we don't necessarily use them as long-term therapies because they do increase calcium cycling. And things that decrease calcium cycling, so beta blockers we use, and calcium channel blockers, right? If you think of theoretically calcium channel blockers, decrease calcium cycling. And clinical scenarios, right? A myocardial infarction decreases your ability to calcium cycling. And here you can see, obviously with if you add an inotrope, you're going to for a given muscle length, so for a given preload, you're going to be able to generate more force. And same thing if same thing if you take away the inotrope, if you have a negative inotrope. So if you have a beta blocker, when we say, when you give diltiazem, let's say to a patient who has a reduced ejection, we say, no, don't give diltiazem, it's a negative inotrope. It's exactly for this reason, that by decreasing their calcium cycling, their affinity for calcium, you're going to decrease the amount of force that they can generate for a given preload or a given muscle length. And this is just showing on a pressure volume loop. You can see that if you increase contractility, it shifts to the left. If you decrease contractility, it shifts to the right. And, you can see that contractility also can generate differences both in stroke volume as well as in the pressure that's generated. So I think this is just important to keep in mind that we use ejection fraction all the time. You guys use ejection fraction, everyone does. And we do this because we don't really have a great way to describe ventricles. But important to keep in mind is ejection fraction is actually a relatively fluid measurement to some extent, which is, as we just saw, if you look at all these different stroke volumes relative to their end diastolic volume, that depending how you vary afterload and depending how you vary contractility, and to some extent, depending how you vary preload, you will all end up with different ejection fractions in the exact same ventricle. So, I think it's important to keep in mind. So that patient that comes in with a blood pressure of 220 over 120 and their ejection fractions, they have an EF of 40, and then you put them on their antihypertensives, maybe you put them on nitrite, you put them on nicotinamide, whatever you do to lower their blood pressure and lower that very high afterload or systemic vascular resistance. And then 2 days later, you check their echo again, and now the EF is 50%. It's not that they reverse remodeled in 2 days. It's that by decreasing their afterload, you've changed the parameters within their ventricle that they're operating on. You've changed their ejection fraction. So ejection fraction by no means is fixed for each ventricle. And I think that is an important concept to keep in mind. Diastole a little bit. There are two distinct aspects of diastole. One is essentially passive relaxation, or the extent of relaxation, and kind of like the diastolic properties of the myocardium, whether it's its stiffness or compliance. And then two is the rate of relaxation, so how fast the ventricle can relax. And that tends to be actually the most active process throughout the myocardium, which is actually relaxation is more energy dependent than any other process. And that's why, one of the first things that happen if you take care of a patient who's having a myocardial infarction and is ischemic, right? So then one of the first things you'll notice is that their filling pressures are up, their ventricle is stiff, they may be in heart failure, and that's because they're unable to relax, or they've lost that ability because it's so energy dependent, and they have a decreased ability to utilize energy in the setting of this active ischemia or myocardial infarction. So when looking at diastole, there's the EDPVR, the end diastolic pressure volume relationship, which is basically shows, what is the properties of the ventricle from a diastolic perspective. So essentially it starts off, you can see that it's not linear the way the systolic relationship is, but that it's at a certain point, you add volume, and originally there's very little resistance to filling. And then at certain points, you get exponential increases in pressure with each additional volume. And how fast that happens, or that relationship is determined by the properties of the myocardium, or their stiffness or compliance. And what you can see here is that for any given ventricle, right? So any given ventricle can operate on different points of its diastolic pressure volume relationship. So it can have normal filling pressures, it can have low pressures, and it can have high pressures depending on its volume. And so, and the other thing to keep in mind is that as ventricles remodel, this relationship changes as well. So if we think about patients with a restrictive cardiomyopathy, or what we call HFpEF, a lot of times what we'll see is that they've shifted to the left, so that for less volume, they have higher pressures. So we say these are ventricles that have very high filling pressures, or even restrictive filling pressures. And with HFrEF, or heart failure with reduced ejection fraction, or dilated cardiomyopathies, a lot of times what we see is the opposite. So the heart dilates out, so that for any given pressure, there's actually more volume. So I can say, well, okay, the wedge pressure is 20, or the LVEDP is 20, or 25, or 15, but that can mean something very different depending on what type of ventricle I'm talking about, right? So if I say the LVEDP is 20, and it's a restrictive cardiomyopathy over here, Well, an LVEDP of 20 may not be very much volume at all. It may not be that you need to diurese it much at all. It may just be that that's where, unfortunately, they operate, which is with high filling pressures. On the other hand, if I say that this ventricle with reduced function has an LVEDP or a wedge of 20, that may mean they have quite a bit of volume, and you can diurese them down and lower their filling pressure. So there's the properties, the filling pressures are very much dependent on these properties. And we use a term capacitance, which is essentially talks about what the volume is at a specified pressure, or essentially kind of sums that up, that idea that, it's not just, it's taking, we do this in our mind whenever we're treating patients. It's taking the parameters in the context of the clinical scenario, or so taking your pressures, if someone gives you hemodynamic pressures and interpreting them within the clinical scenario of that patient or that cardiomyopathy, whether it's HFpEF, whether it's HFrEF, whether it's restrictive, whether it's dilated, whether it's someone with a normal heart. So I think that's important to keep in mind. And then the other part is lusitropy, or active relaxation, which we talked about is a very is the most active or most energy dependent part of the cardiac cycle. And essentially what we call is we use a constant called tau. And essentially what tau is it's not a concept, but it's a term that describes the amount of time that the ventricle takes to relax in this energy dependent process. And that can be very different for each ventricle. So a normal ventricle will have a normal tau, but someone with HFpEF or HFrEF, they may have a much longer tau, which means it takes much longer for them to relax because of the cardiomyopathy that they have. And different things can change this rate of relaxation. So it's very ATP dependent. And so ischemia obviously will change it. Beta agonist will change it. Changes in heart rate can change it. And it plays a big role. So if you look here, so this is a patient who has a normal tau of 20 milliseconds. And you can see that if you take the heart rate and you increase it from 60 to 120, which is what we're doing right now, here's your end diastolic pressure volume relationship and systolic pressure volume relationship. You can see that the patient becomes more tachycardic, which is expected. The stroke volume becomes less because you fill less. You can see the preload went down, which is expected. The pressure generated is higher, which is expected. But overall, the patient tolerates it quite well, and the cardiac output would go up. But if you take a patient now and you say, instead of a tau of 20 milliseconds, I'm going to make it 75 milliseconds, which is quite long, which means I'm going to take a ventricle now that needs a long time to relax. And then I say, okay, and I'm going to increase the heart rate from 60 to 120. Let's see what happens. Okay, it froze on me here. At 75 milliseconds, now we're going up to a heart rate of 120. What you see is what's happened here. So what's happened here is obviously your stroke volume has gotten, I'll freeze it next time it gets there if I can. Your stroke volume has gotten, let's see if this picture shows it better. Okay, so what you see here is that the stroke volume gets very small. Your blood pressure, actually your systolic, gets quite low because your cardiac output gets so low. Your pressures, your end diastolic pressures, you can see here are much, much higher. And you're no longer even on the relationship curve. You're no longer on your end diastolic pressure volume relationship. So what's happened is essentially, as you can see here on the left, is that because your rate of relaxation is long, and the heart rate now is quite fast, there's not enough time for the heart to relax. And so at these high heart rates, what you end up is a heart it's called incomplete relaxation. And when you have incomplete relaxation, what that means is that when the heart goes to fill for its next beat, it hasn't fully relaxed. And so your pressure is still quite high. And so now you have very, very high filling pressures because of the high heart rate. And what essentially happens is now you have a patient who can't generate enough cardiac output, whose blood pressure is very low, and who's very short of breath because of the high filling pressures. It's the middle of the night, everyone's panicking, they're giving fluid. It takes a ton of fluid to get up to enough blood pressure, enough just to maintain a blood pressure. And that's all because of this inability to relax. And so this is something quite common, right? How often do you see a patient who has heart failure who goes into AFib with RVR? Next thing you know, they're in pulmonary edema, hypotensive, and either on BiPAP or whatnot. And it's what's driving that. It's this concept drives a lot of it, which is that inability to relax, right? So the filling pressures become very high, the stroke volume becomes very low, and the cardiac output becomes quite low as well. And so to reverse it, you need to slow down the rate, diurese. And just to show you, from a volume perspective, so to get to enough cardiac output, just to generate cardiac output where you were, as you increase that heart rate, here, a normal CVP, so this is a normal right atrial pressure is 4, but now you need a right atrial pressure of 12. But before they had a wedge or a left atrial pressure of 6, and now it's at 23. We consider above 15 to be very abnormal. And so this can play a big role in some of the hemodynamics that we see, is this active relaxation. Okay, so we've talked about preload, afterload, contractility, diastole, and lusitropy. We'll try to run through some myocardial oxygen consumption quickly. Here's an exercise. For the sake of time, we'll keep moving. And so let's talk a little about myocardial energetics. So the heart has a very high energy demand. The two main processes that are energy dependent is the sequestration of calcium by the sarcoplasmic reticulum and the uncoupling of actin myosin type bonds essentially during active relaxation. And myocardial oxygen consumption is basically proportional to the amount of work that the heart does with each beat. And when we look at this pressure volume loop, we look at the area inside the curve. I said the width is the stroke volume. The entire area inside the pressure volume loop is called the stroke work, this is the entire mechanical work that the heart is doing with each beat. And if we think about it, what it really is if you take the map, because we said this is the map of, and we take the stroke volume across, and we multiply it, which is the area of this, then you'll end up with the stroke work. And a lot of times in cardiology, you'll see in studies, we talk about cardiac power. And cardiac power is essentially, so if you took here like we did, if you say the stroke work, which is the map times the stroke volume, and then you multiply it by the heart rate, then you have essentially cardiac power. We divide it by 451, which is a constant. And essentially what that says is when someone says, oh, the cardiac power is 0.7 or 0.6 is usually a cutoff that we use when we're thinking about shock. And below 0.6, a lot of, there are studies looking at saying that maybe you need mechanical support at that point. But what we're really saying is how much mechanical work is this heart capable of doing? And if you go back to the original shock trial, which was by Judy Hoffman, so if you think about it, in 2004, this was the initial trial with STEMIs, showing that, nowadays we take it for granted that, okay, if there's a STEMI, you have to do PCI, but that was a trial which showed that, yes, if you do, in shock, cardiogenic shock, doing PCI for STEMIs is, has a mortality benefit. But one of the biggest predictors of survival is cardiac power, is saying, how much mechanical work can that heart do? And when we think about energetics, so in truth, it's more than just the stroke work, right? So if you look at so the stroke work we said is this pressure volume loop. And if you look at this green area here, this is actually what we call potential energy. So what that means is at the end of each beat, there's still a lot of energy that is essentially somewhat wasted, right? You have all these bonds that are still together and not to come apart. There's heat, there's so forth. So there's a lot of energy that's not completely utilized. But if you look at these two areas, right, which is the potential energy and the stroke work, that's called your pressure volume area. And this is what we consider to be the total myocardial oxygen consumption. This correlates with the total myocardial oxygen consumption. And, it's important, myocardial oxygen consumption is a bit of an abstract concept, right? It's not like we walk around all day on, the wards, and we say, oh, drive his oxygen consumption lower, drive his higher. I mean, we don't really treat patients, right? Acutely, we treat hemodynamics and heart failure. Long-term, we treat neurohormonal activation. But a lot of the principles that we use in the background are truly guided by myocardial oxygen consumption, right? So if you think about a lot of the therapies, a lot of the reasons we use them are to drive down myocardial oxygen consumption, because the theory is that if you decrease the amount of work that the heart has to do, you allow the heart to function better, to potentially recover if you're dealing with ischemia and so forth, to lessen the insult if you're dealing with ischemia. So it plays a role in a lot of what we do. And, so in talking about, so feel free to jump in. So what are the main determinants of myocardial oxygen consumption? Feel free to jump in, anyone. I think drives consumption.
You mean like
preload? So afterload, great, really good. What else?
Heart rate.
Heart rate, great. And contractility, right? So these are probably a lot of the main parameters of what drives your myocardial oxygen. So how much preload you have, right? How much afterload you have. Contractility, right? So we talked about if you're using inotropes to increase your contractility, you're probably increasing your myocardial oxygen consumption, right? Because you're increasing your calcium cycling. If you're using beta blockers, which decrease your calcium cycling, you're decreasing your contractility, you're probably decreasing your myocardial oxygen consumption. And heart rate is a great point, right? Because in the end of the day, if we talked about the most energy dependent parts being sequestration of calcium and actin-myosin uncoupling, well, the more times you do that, or the more beats you have, the more myocardial oxygen, the higher your myocardial oxygen consumption is going to be. And so if we look here, it's exactly right. So if you look at this on the right, you can see that every cell and every myocyte and every myocardium as a whole has a basal metabolism, which is unchanged. Nothing you do changes that. There's calcium cycling, and we just talked about ways that can change your calcium cycling, which is through inotropes, negative inotropes, ischemia, and so forth. All of those change your calcium cycling and change your oxygen consumption. And then there's your mechanical work, which is usually dictated by your preload and your afterload and where you fall within those parameters. And you can see here, so if you look, this is afterload. So afterload, this is a pressure volume area. So you can see that for a given afterload, as you increase afterload, you're going to move along the slope of this line to different relationships, which will increase your myocardial oxygen consumption. And preload is no different, as you see here, that you'll move. Now, so both of them will move depending on how much preload and how much afterload you use. You'll have different configurations of your pressure volume area and different amounts of myocardial oxygen consumption. Now, calcium cycling is a little different, right? We talked about like if you add, let's say you add an inotrope and you increase your calcium cycling, milrinone or dobutamine, or even Levophed, which you guys use a lot, has some inotropic properties, right? All of those increase your calcium cycling. So you'll actually shift your curve so that you will have a significantly more myocardial oxygen consumption with an inotrope or an inopressor, let's say, than you had it without it. And same thing with if you utilize beta blockers or calcium channel blockers. If you have ischemia, all of those will decrease your calcium cycling. Now, so here you can see contractility, and you can see that basically as you shift contractilities, if you can imagine it shifting here, you can see that you actually shift to a different, you shift your whole pressure volume area, your whole relationship, and you have much more myocardial oxygen consumption. But in truth, the biggest driver of myocardial oxygen consumption is your heart rate, right? So in the end of the day, if you look at it on a per beat basis, of course it's the same, but if you look at it on a per minute basis, high heart rates are going to drive myocardial oxygen consumption more than anything else, right? And if we think about therapies that you're going to, that you use all the time, right? So the cornerstone, now we have multiple therapies we use, let's say in heart failure, but the cornerstone therapy is a beta blocker, right? That was the second therapy that was that came about after ACEs and ARBs. And we know that beta blockers probably have the biggest mortality benefit of all of the goal-directed medical therapy we use in heart failure, and probably the biggest effect on reverse remodeling too. So when we say reverse remodeling, we mean the ability to take a ventricle and improve its actual structure. So, improve its EF, improve the amount of LV dilatation, change the actual structure of the ventricle, allow it to reverse remodel back to more of its original form. And, beta blockers have many ways that they do that, by blocking. The key things that heart failure is involved in is blocking neurohormonal activation, whether it's sympathetics or RAS, and beta blockers block sympathetics. But one of the main aspects of it is that they drive down heart rate. So over time, right, as you ratchet up your beta blocker, you drive the patient's heart rate down. And that heart rate reduction over time leads to significant reductions in myocardial oxygen consumption, and probably has a probably plays a huge role in why beta blockers are so beneficial long-term for heart failure, and vice versa, right? So inotropes, that you guys will probably be, I'm sure you're all exposed to as residents. We use inotropes as a bridge to therapy. So we use them essentially if a patient's in shock and they have end organ dysfunction, so renal dysfunction, liver dysfunction, they're hypoperfusing, they're not perfusing their brain. We use inotropes to perfuse the rest of the body. And we use it sometimes for the same reasons from a palliative perspective, so they can feel better. But as far as outcomes, right, all of the data, there's no data ever showing mortality benefit. And in fact, the vast majority of data shows increased mortality with inotropes. And earlier on, a lot of that data maybe was driven by sudden cardiac death and so forth. But the truth is, a lot of it is a lot of the reason why inotropes are not beneficial long-term as a therapy is probably for the same reason, right? So in the end of the day, yes, you increase contractility, but you do it at the expense of increased calcium cycling. And when you do it at the expense of increased calcium cycling, you're increasing your myocardial oxygen consumption. So you're essentially working the heart harder to generate that extra cardiac output, which in the short term works when the patient's crashing, but doesn't work in the long term. And that's why we don't use it as a long-term therapy or treatment. So let's just finish by talking about HFrEF. And what happens in HFrEF, or heart failure with reduced ejection fraction or a dilated cardiomyopathy, is you have afterload mismatch. And what you have is you have a ventricle where the contractility is depressed, for various reasons. It could be an ischemic cardiomyopathy, it could be a hypertensive cardiomyopathy, it could any of the reasons why you could have a heart failure with reduced ejection fraction. And when you have contractility that's depressed, and you have a decrease in your stroke volume, your body increases, right, all the systems that the RAS system, the sympathetics, all of that is increased to try to increase your cardiac output and increase your blood pressure. And what it does is it increases your afterload, your vascular resistance. So you have decreased contractility and increased vascular resistance. And you also have, because your RAS system is initiated, you have an increase in preload too, because the body tries to hold on to as much fluid as it can because it's trying to generate more cardiac output. Even though we know that long-term, these systems don't work. They're more part of an initial fight or flight type of system. And so what you have is you have a patient that has very high preload. So they're on that flat part of the Starling curve, right? They're not really generating any more cardiac output from that increase in volume. And they have a high afterload. And they have no mechanism to make up for the high afterload because there's no preload that can counteract that. And they have a decreased contractility. So all of that leads to that cycle, which is what you see when a patient comes in with decompensated heart failure. And the thing to keep in mind is all of this shifts when you have all of these interplay with each other. So if you have increased afterload, well, your Starling curve becomes less effective at higher afterloads, and vice versa with lower afterloads. And same thing with contractility. Your Starling curve becomes less effective. If you have a heart failure with reduced ejection fraction, you have less of an ability to increase cardiac output with preload. So you have a downward shift because of contractility in your Starling curve. And same thing with your force tension relationship. So same thing with afterload, is you're more affected by afterload, and as far as your ability, higher afterloads make you less able to generate force. And I just bring this up here. I talked about at the beginning when we talked about the Starling curve, and I said, look at it. And you guys correctly pointed out that it flattened out, and but what I pointed out is I said, well, but there's no negative aspect of the Starling curve. And now I'm showing you here a Starling curve where there actually truly is a negative. The slope does become negative towards the end. And I think this is the difference. This would be an abnormal ventricle or heart failure with reduced ejection fraction. And the reason why this would be is because of some of the concepts we talked about. So as you have your RAS system and your sympathetics all increased, you're going to retain fluid, and you're going to have higher filling pressures and higher afterload. And when you have higher filling pressures and higher afterload, you're going to have higher wall stress. And when you have higher wall stress, you're going to have a decreased ability to generate force or to contract. And you're going to have pulmonary edema and probably acidosis, which is going to affect your ability to contract also. So all of those things together will get you to a point where you'll have a certain point where your filling pressures, your end diastolic pressure is actually high enough now that it's actually contributing to a negative effect on your cardiac output. And by diuresing, right, you may actually improve your cardiac output. It may not be a whole lot, right? We see here, maybe you go from 3 to 4, or you see some, but you will increase your cardiac output to some extent in these scenarios. So I just wanted to bring that up to just show you the difference between a normal ventricle and a ventricle with reduced ejection fraction. This is just showing this is just the relationships we talked about, what you see when you have HFrEF, which is essentially a decrease in contractility. It shifts, higher preload. You can see a higher end diastolic pressure volume relationship, smaller stroke volume, and less ability to generate cardiac output as a whole. So just a question, we just talked about, how does diuresis affect cardiac output in HFrEF? It decreases cardiac output, it increases cardiac output, or it depends? Anyone?
It can help increase cardiac output by getting rid of afterload.
Okay. What else? That's good.
But it could also decrease cardiac output when you get rid of some of the preload.
Correct. What other mechanism? I like that. What other mechanisms can it increase cardiac output by?
I mean, you could also.
So we talked about wall stress, right? So if you have high filling pressures and your LV or your RV is dilated because you have so much volume on board, and then you diurese and you drive down your filling pressures, you decrease your diameter or radius, you'll decrease your wall stress and improve your contractility, right? So that's another way. What about the other thing we see very commonly in heart failure, right, is mitral regurgitation. It's very common to see that, as you have ventricles that remodel or dilate, the heart stretches, and because it stretches the valves apart, and you see a lot of leaky valves. So that's the other thing, is a lot of times you diurese and you decrease the amount of regurgitant or the amount of backwards flow, essentially, and increase your cardiac output. So the answer is it depends, but you can decrease it by preload, exactly as you said, and you can increase it by improving your mitral regurgitation, decreasing your wall stress, and also there is a certain component of just having increased intravascular volume, which does lead to pressure. And so by driving that down, you will decrease a certain form of your afterload. So just to remember, I think in acute heart failure, the idea, is basically restore your normal hemodynamics. And a lot of times we use vasodilators for that, minimize your filling pressures. We use diuretics for that, and minimize your oxygen consumption, which is a little bit more of an abstract idea, but something that plays a role in a lot of what we do. And in cardiogenic shock, to keep in mind that, a lot of times you'll see us using inotropes and pressors, but remember that those both increase afterload. So if you're using, let's say, levofed or phenylephrine, you're increasing afterload on the ventricle. And if you're using inotropes, you're increasing your myocardial oxygen consumption. And, as we use, this is beyond the scope of this talk, but sometimes we use different mechanical support options, and we think about some of these hemodynamic parameters and energetics and how they interplay on the heart. I think maybe we're out of time. I don't know. But thank you very much. If you have anyone has any questions,